Okay, here is Chapter 18, Oral and Maxillofacial Surgery. We're starting on page 698, but we'll start the actual lecture part on 699. You can see that this chapter is significantly smaller than orthopedics, so this lecture will also be smaller, shorter. Okay, so basically, oral and maxillofacial surgery. So this is any surgery in the mouth, anything on the face. A lot of it is well, some of it can be cosmetic. So we're starting on page 699. There's the introduction and the diagnostic tests, and I will try to define the words in red. I don't have my notes out, so I'll get those out while I talk to you. But in that second column, towards the bottom of that big paragraph, the second to the last one in red, a panoramic x-ray shows on one film the alveolar processes, mandible, posterior maxillary sinuses, and zygomas. So let me find, there's my key terms. Okay, so you have in red on the left-hand side maxillofacial, and maxillofacial is just pertaining to the face and maxilla, and panoramic, pan means combining, it's a combining form meaning all, and then the alveolar processes, that is the part of the mandible or maxilla that forms the dental arch, which contains the sockets for the teeth. Okay, so I'm now on page 700. I mean, there's a whole lot of slides that were between the last audio and this one about the diagnostic test, but what I do want you to know on 700 at the top left, that MRI best defines soft tissue injuries or congenital defects. So this is going to be the diagnostic test that really shows where the injuries or the malformations are at, and so we don't just rely strictly on X-ray for these types of instances. We do an MRI. Okay, so now I'm on page 701. On that instrument set list on table 18.1, there's the dental set. A lot of you will not be doing a lot of dental cases unless you work at a dental office or an oral surgeon's office, but we still need to cover this because you may be doing some maxillofacial surgeries where you do enter through the mouth, like through the gum line. So we have to know these things. So under the dental set, you can see there are mouth props, and mouth props are, that's just a self-retaining retractor used to keep the mouth open during oral and dental procedures. But what I really want you to focus on is the seventh one down, that Minnesota retractor. So anytime you see Minnesota, I want you to equate that with oral and maxillofacial surgery. So the Minnesota retractor. Now you can see the mouth props are at the bottom of 701, and then there's a plastic cheek retractor. So that's what that looks like, just to hold that patient's mouth open. Since they are asleep, they cannot control that. They have to be propped open. Okay, so I'm on page 702, and at the top left you can see the Minnesota retractor, and I just put right next to that picture, it's used in oral procedures, and it's a double angle retractor. That latter part, make sure that you know that for upcoming quizzes and tests. So this is used in oral procedures, and it is a double angle retractor. So these bullets are continuing from page 700, the procedural considerations for any tooth extraction, which is also called an odontectomy. And so that third bullet about the patient prep, it goes into some sub bullets, and you need to know both of those sub bullets. A turban style head wrap may be used to restrain the hair, and a throat pack is dampened rolled gauze that contains a radio-opaque marker. It is included in the formal count, so we have to count these throat packs. It is used to prevent oral secretions, irrigation fluid, blood, and bone or tooth fragments from becoming lodged in the pharynx, and it must be removed prior to extubation. Okay, so that will take us into our first procedure, which is the tooth extraction or the odontectomy. So under the pathology and the anatomy, that first bullet, we'll start on the second sentence. The side of the tooth that lies closest to the lips is referred to as the labial. And going back to our anatomy and our medical terminology, labial, that's again just it means lip. So side of tooth that is closest to the lips. The tongue side is lingual, cheek side is buccal, which going back to pharmacology, if you had a buccal, like if any kind of pill that had to be like a buccal, it goes into the mouth, so you put it into your cheek and let that dissolve. So each tooth is embedded in a socket of the alveolar process. The alveolar maxillary process contains the upper teeth, and the mandibular process contains the lower teeth. And then you have your incisors, the four front teeth used to tear food, your cuspids, which is lateral to the incisors, used to grasp and shred food, the bicuspids, which are distal to the cuspids, used to break up food into smaller portions, and then your back molars, those are your flat top teeth, also used to break up food. The three regions of a tooth, there's crown, which is the portion above the gum line that we see, the root, portion below the gum line, and then the neck, the junction of the crown and the root. So the crown is covered by enamel, which is the hardest part of the tooth. Dentin forms the majority of the crown. It is harder than bone and encases the pulp. The pulp contains the blood vessels, nerves, and connective tissue. And then going on to the next column at the top, the cementum is a bone-like substance that covers the tooth from the termination of the enamel at the neck to the thickest region at the apex of the root. And then I need you to know those last two bullets. Simple extraction is removal of the tooth from the alveolar socket with extraction forceps. And odontectomy involves resection of the soft tissue and excision of the bones surrounding the tooth prior to removal of the tooth. Excuse me. So under the surgical procedure, I want you to look at number 3 in the procedural considerations. There's that Minnesota retractor. I just have it underlined to demonstrate when you will use this retractor. Okay. And then on 704, under immediate postoperative care, that first bullet, second sentence, occasionally re-intubation is necessary and a laryngoscope and ET tube should be readily available. Additionally, a tracheostomy or tracheotomy tray should be available in the OR and, and transported to the patient to the PACU, with the patient to the PACU. Excuse me. And then under prognosis, you see in the third column, there's in red that malocclusion, and that's just abnormal alignment of the teeth of the upper jaw with those of the lower jaw. So your teeth are not aligning with each other, which is going to cause wear and tear on that crown part of your tooth. And so at the bottom, there's that pearl of wisdom, and I need you to highlight it. It's just reiterating what we underlined on page 702 about the throat pack. You're going to have to excuse my voice. For some reason, I'm hoarse today. So that was pretty much all that we're going to cover about teeth. Again, because we don't really work a lot with teeth, they hire their own scrub techs to work with teeth. And so basically, if a patient's coming to the OR, we're going to be doing maxillofacial procedures. Sometimes you will see dental procedures being done in the OR on children because they have to have a lot of either extractions or they're getting a lot of caps on their teeth, in which case usually that dentist will bring their own scrubs. So, unless you're working in a dental office, we just need to look at the maxillofacial procedures, which is on 705. So under the general considerations, make sure you know the first three bullets. Maxillofacial injuries can inhibit speech. Any facial imaging studies, dental impressions, or preoperative photographs should accompany the patient to the OR, and the surgeon will typically stand at the head of the OR bed. All right, the fifth one, blood loss should be measured closely, especially in children. Maxillofacial surgery involves manipulation of the bones near the patient's airway. That's why we have to have that tracheotomy or tracheostomy tray accompanying to PACU, just in case some occlusion does happen in the throat or in the air, somewhere in the airway. Okay, that last bullet that continues to the second column, facial hair is removed if necessary. However, eyebrows and lashes should never be shaved or removed because they can grow in differently. And then the next bullet, a dural tear may be repaired by the maxillofacial surgeon by placing a suture or by sealing off the cerebrospinal fluid leak with a fat, fascia, or muscle graft. Open reduction, and again, reduction is correction or placement of a body structure back into normal anatomical position. So open reduction techniques often require the use of internal fixation devices and can involve a variety of graft materials. So again, we're dealing with with screws, very very small titanium, flexible mesh plates, etc. That second sub-bullet, autogenous bone grafts are harvested from the iliac crest, ribs, or calvarial bone. And calvarial is pertaining to the superior portion of the cranium where the fontanelles or fontanelles of the infant are situated. So we can take graft from up on top. And then that second sub-bullet, homogeneous bone, is from a cadaver and is obtained from a bone bank. Xenograft material such as coral is often used, that's pretty cool, and synthetic material such as silastic may be used. Next bullet, the surgical tech may also be expected to fill the role of the surgical assistant. So because there's only so much space by the head where the surgeon is, there's really not a whole lot of room like an LAVH to get a whole lot of people in there. So sometimes you'll be retracting with your left hand and you'll be passing with your right hand because it's all just one little area right there. Okay, I've skipped over to this slide. The previous slides kind of just grazed over what we just talked about in the book, but you can see, I mean, we're almost finished with this chapter already. It's pretty quick. So let's go on to 706, the repair of mandibular and maxillary fractures. That second column towards the top, non-absorbable implants are most commonly used for facial fractures in adults. Titanium is a strong, lightweight, non-corrosive metal that is used most often in craniofacial procedures. So we're saying yes to titanium. And then at the bottom, that little paragraph, arch bars are used to immobilize the jaw following mandibular and or maxillary fracture. So that will take us into our second procedure, that application of arch bars. Yes. So we'll just stay on this slide. All right, so under the anatomy, the maxillary bones meet inferior to the nasal septum to form the upper jaw. The point of connection is called the intermaxillary suture. Next bullet halfway down, the maxilla does not articulate with the mandible. The frontal and ethmoid bones articulate with the maxillary bones. And then that last bullet in this column, the upper teeth are located in the maxillae. The alveolar portions of the teeth are located in the alveolar process in the maxilla. Okay, third third bullet in the second column, the largest and strongest facial bone is the mandible. It articulates with the glenoid fossa, which is the socket in which the head of the humerus articulates to form the shoulder joint. So this is a ball and socket joint. Okay. So again, it articulates with the glenoid fossa of each temporal bone to form the synovial joint called the temporomandibular joint, or TMJ. And this is the joint that that's formed by the mandible that articulates with the glenoid fossa in each temporal bone. And we'll talk about TMJ, I think, more at length here in a minute, because a lot of people do have TMJ, that clicking when they chew or when they yawn. We'll talk about that here in a minute. The mandible consists of three portions, the first being the body, which lies horizontally and contains the alveolar process for the lower teeth. The mental foramen is located on the body and below the first molar tooth. And the mental protuberance is the chin. And I need you to draw a line, and you're going to write something in the white right under that. So the mental protuberance is the chin. It's also called the mandibular symphysis. M-A-N-D-I-B-U-L-A-R. Mandibular symphysis. S-Y-M-P-H-Y-S-I-S. So the mental protuberance is the chin, also known as the mandibular symphysis. The second portion is the ramus, and the ramus is a smaller branch of a structure that extends from a larger branch that divides into two parts, such as the rami of the pubis. The rami project upward at an angle from the posterior part of each mandibular body. And then about halfway down, the coronoid process is the anterior projection of the ramus. The temporalis muscle attaches here. And you can see all this on page 707. I'm going to have you actually just go ahead and travel with me to 707. On the right-hand side at the top where it says temporalis, okay, go ahead and underline that. I want you to see that that is where it's originating, right there towards the top of the cranium, and it goes down into the cheek area. And then that last bullet on this page, condyle, and a condyle is the rounded projection or process at the epiphysis of a bone that articulates with another bone, which we learned in the last chapter. It serves as the point of attachment for ligaments. So condyle fractures occur within the capsular head of the mandible, and subcondylar fractures are below the capsule. Next bullet, the last area of the mandible is its angle. The angle connects each ramus to the body. And then at the bottom of that column, symphysis, and symphysis is a joint in which the two bony surfaces are joined by fibrocartilage, also known as meniscus. So symphysis and parasymphysial fractures occur along the mandible between the bicuspid teeth. Most of these fractures do not dislocate, so that's a good thing. But you can see in that figure 18.7, that mandibular fracture, you can see where the condyle is in the ramus, and then there's that fracture. That's a very common area to get a fracture right there. Okay, so continuing on to page 709 under practical considerations, so we're still talking about arch bars. About towards the bottom of that first column, to prepare the wire, so the wire to make the arch bars, you're going to cut segments slightly longer than needed, so approximately 10 centimeters. Okay, that's important. And then that last bullet, the wire is tightened in a clockwise manner during application and removed by twisting in the opposite direction. Okay. So you can see, so we're putting on arch bars so that mandibular fracture on 708 that you see can remain still, so we're not moving our jaw to chew, to talk, or anything. We're closing our mouth so that can heal properly because we can't put a cast on a mandible. Okay, so you can see on 710, this is what arch bars looks like, the maxillomandibular fixation on that figure of 18.8. So they are drinking through a straw. Okay. All right, you need to write something next to this picture. So this is talking about the postoperative considerations, but you need to write that the head is elevated post-op to minimize edema. The patient's head on the way to post-op and in post-op will be elevated to minimize edema, E-D-E-M-A. So in the immediate postoperative care, that second bullet, scissors or wire cutter should accompany the patient to PACU. So in case the patient needs to vomit or something is about to happen that's going to compromise their breathing, you have to be able to cut those arch bars off really quick. Tracheotomy may become necessary secondary to airway obstruction due to swelling. So again, we're taking a tracheotomy tray into the post-op area. And then on 7-11, that pearl of wisdom, make sure you know that second sentence. The strips, which is the arch bar strips, are malleable and the hook should be placed pointed downward on the lower jaw and upward on the upper jaw. And you can see this in that picture on the previous page. So if you look at the bottom of the mouth, those hooks are facing downward. Those upper parts, that's facing upward, okay? All right, so that takes us to the plate and screw fixation of mandibular fracture. I don't really need for you to know anything about this procedure. However, I need you to look on page 713, the the pearl of wisdom. So this sequence of events, it says, is employed for attachment of plate to bone with most fixation systems. So this can be applied to orthopedics, and I wrote that underneath this yellowish brownish table, same sequence as ortho. So you're going to select a plate with the appropriate thickness, length, and design. Okay, you're going to contour that plate if needed. You're going to get the drill bit that's chosen. Drill guide is going to be put on that plate. You're going to drill. You're going to depth gauge, you may have to tap, and then you're going to screw. Drill, depth gauge, screw. Drill, depth gauge, screw. Same thing, same sequence all the time. All right, so that is going to take us to the next page, 714, the orbital floor fracture repair. So under the anatomy, the bones of the orbit support and protect the eyes. Each orbit consists of the following 7 craniofacial bones: frontal, lacrimal, ethmoid, maxilla, zygomatic, sphenoid, and palatine. Okay, yeah, we are almost done with this. Good deal. Second bullet, continuing into the next column, trauma caused by auto accidents, fights, and falls commonly results in these fractures. So this is the blow, the punch to the eyeball. They're going to fracture that orbital floor down below. And then the next, that first bullet in the third column is talking about the characteristics of the orbital fractures. The first one is diplopia. Make sure that you know what diplopia is and enophthalmos. Diplopia is double vision. Okay, and I'm going to pull up Google really quick. I'm going to read verbatim what this says. Am I still recording? I should be still recording. Yes, okay. So I'm going to just define this because I want to, yep. Diplopia is the medical term for double vision or seeing double. And then enophthalmos, there we go. That is the posterior displacement of the eye. Okay, so this is when someone's eyeballs are not they're not matching up. Okay, so there might be a prominence, there might be a drooping, but it's just, I'm looking at images right now. It's a drooping. It's very, like, these are the people where you don't know which eye to look at whenever you're talking to them. This is enophthalmos. Okay. So those are the 2 characteristics. Make sure that you know what those are. So in the surgical procedure, so again, you can see on that figure 1810, the orbital floor fracture. You can see that little, and it's very tiny, very, very delicate bone right there underneath the eyeball. We are going to put plates and screws. So make sure that you know on number 6, the procedural consideration, you want to have a pre-moistened retractor of choice available. So what I'm really wanting to look at is that the retractors that are going to go into underneath the eyeball, they need to be moistened, because if you pull out, you may be dragging the eyeball with it. And so just make sure that it is pre-moistened. Okay, so that will take us to 716, the Lefort 1 fracture repair. So under the anatomy, the pair of nasal bones come together to form what is known as the bridge of the nose. Each nasal bone articulates with the frontal, ethmoid, maxillary, and the opposite nasal bone. The zygomatic bones, which are the malar bones, that's the malar is your cheekbones, form the prominences of the cheeks and a portion of the inferior and lateral wall of the orbit. Lefort 2 fractures, also called pyramidal maxillary fractures, may be triangular or pyramidal in shape. The vertical fracture line extends upward to the nasal and ethmoid bones. Lefort 2 fractures can be unilateral or bilateral in nature. And then in that third column, second bullet, Lefort 3 fractures, also called craniofacial disjunction fractures, are located high in the midface. And then continuing on to 717, that second bullet, a Lefort 1 fracture, also called transverse maxillary, is the most common type of midfacial fracture. And so you need to circle that figure 1811 because you need to see the Lefort 1, 2, and 3 just to get a better understanding of where these are taking place. So A is Lefort 1 down underneath the nose. Lefort 2, it encompasses the nose and it goes into both of the orbits. And then Lefort 3, it's high up on the bridge of the nose underneath the orbits over into that temporal area. All right, so under the surgical procedure on 718, number 1, I want you to look at the incision. Make sure you know the incision. The gingivobuccal sulcus incision. That is the incision that you are using to expose that maxilla. Okay, so we are in the mouth. We're not going to be making any incisions on the face. For vanity reasons, we don't want to have any scarring on the face, so we're going to go up through the mouth. Okay. So that's a Lefort 1 fracture repair. Let's look on page 720, the Lefort 2 and 3 fracture repair. So all I want you to know, since we went over the anatomy, the surgical procedure number 1, now we're making a bilateral eyebrow incision. Okay. Okay, so that takes us to page 721, the orthognathic surgery. So orthognathic, that is surgery to correct conditions of the jaw and face related to structure, growth, TMJ disorders, and malocclusion problems. So in red, it says during orthognathic surgery, a correct jaw alignment and occlusion are achieved. And so malocclusion, right there's the malocclusion, that is classified into 2 groups, that's skeletal and dental. Skeletal malocclusion is caused by differences in shape, size, and or position of one or both jaws. If the jaw alignment is correct in a patient, the dental malocclusion may be the result of an incorrect leaning or crowding of the teeth. So just to make sure that you knew what that is. And that is the conclusion of Chapter 18. Make sure that you look at MindTap to see if there's anything that you need clarification on. Please see me if you need clarification. I will see you in class for our hands-on portion.